time, number 3, which I'm okay with. I'm looking, maybe I might change that. Okay. So, we're looking at upper GI bleeding, lower GI bleeding, obscure, and then occult bleeding. As I just mentioned, right, general lecture covering these GI bleeds. We're going to go into greater detail, specifically on upper GI for this block. Lower GI will be in block 2. There he is, the man, the myth, the legend, old Dr. Trites. Remember that one? Remember that eponym from Anatomy and Physiology? You should. It's a ligament, right? And that ligament separates where we consider things as upper GI versus lower GI, specifically that ligament. And so proximal, upper GI bleed, distal is lower GI bleed. That's the thing, it just attaches right to the jejunum there. So we're thinking duodenum all the way proximal. So acute upper GI bleeds, what's happening in these patients? They've got hematemesis, likely a varying degree of hypovolemia, plus or minus melena. They may have some hematochezia. Hematochezia for upper GI bleed, there's a lot of blood. We'll talk about specifics here in a bit. And again, this is all bleeding proximal to ligament of Trites. So what causes these acute upper GI bleeds? Mostly, and if I ever give you a stat, it's not to memorize the 40% or the 50% or the 60%. What I'm doing is I'm translating most common. That's what that means. Okay. So most commonly, peptic ulcer disease is what causes these acute upper GI bleeds. Portal hypertension due to some type of esophageal varices, also that's a high mortality rate. And when we get into talking more about esophageal varices, hopefully that'll become clear as to why those folks die. Less common causes, we got the vascular abnormalities there. Esophagitis we'll hit on briefly. Mallory-Weiss, Borhe we'll talk about. And then those upper GI neoplasms. How do they present? Hematemesis, vomiting blood. It can be bright red or coffee ground. Why coffee ground? It's partially digested blood. That's weird. It's digesting yourself. Super crazy. Melena, dark, tarry stool. And that can occur with as little as 50 milliliters of blood loss, which is not a lot. Rarely there's hematochezia, only in severe, and look how much of bleeding needs to occur. A liter of blood. Right? So if you're getting someone that's complaining of hematochezia, your first instinct should not be to think about upper GI. It should be lower GI. However, we're coming here, the nuance, a bad enough upper GI bleed can cause hematochezia. And it can be associated with pain, either epigastric or abdominal. So generally, how do they do it, right? Are they sick or not sick? Are they stable or unstable? Look hemodynamically at what's going on. We're replacing fluids, we're replacing bloods. We're going to triage them. We're in the necessary level of care, i.e. do they need to be admitted, or can we just send them home? And then the follow-on care, endoscopy, pharmacotherapy, we'll hit on those. So assessing that hemodynamic status is the first and most important step. And again, it's stable versus unstable. And generally this is talked about and executed as a range. Unfortunately, though, in some of these exam questions, you're only going to get one set of vitals. Okay? So if you're seeing the first set of vitals and you look at systolic blood pressure that is less than 100, you should be thinking unstable. If you see a pulse greater than 100, you should be thinking unstable. Okay? That's the point of this here. Stable would be a normal pulse, normal blood pressure. If they are unstable, what do? We get our safety net. You hear that all the time. We're starting our IVs. We're also drawing labs, CBC. Why? We're looking at blood, right? We're looking at hematocrit. That's what we're doing. We're looking at hemoglobin. CMP, looking at electrolytes, looking at the liver. PT-INR, understanding what might be causing the bleed. We're doing a type of cross-match as well, because these can be bad. They can be super bad. We're starting fluid replacement. Isotonic fluids, normal saline, LR. And then 2 to 4 units of packed red blood cells, emergency release O-neg, if necessary. NG2, yes or no, can do that, not always necessary. In the literature, this is wishy-washy there, but certainly can help you with diagnostic stuff as well. And when you get into general surgery, they're going to tell you something completely different with regards to that. Here I'm going to tell you, on the GI side, they're kind of whatever. Right? Several scoring methods when it comes to triage. Generally, what I want you to take away is that are they high risk, meaning high risk for death, or are they low to moderate? If they're high, they're going to the ICU. And what does that mean, going to the ICU? We're talking ratio of care. That's what that means. So in the ICU, it's 1-to-1 nursing. So staffing shortages, staffing requirements are what determine what it establishment may or may not have an ICU. On a step-down unit, or a medical unit, surgical unit, the ratios can be as high as 10-to-1. Okay? So that's the difference. A 1-to-1 ratio on the nursing side means that this patient is super sick and needs constant attention, very complex, lots of things going on. Those are some of the smartest people in the hospital. Right? There's also some of the most overly caffeinated drugs. Be nice to them when you meet them. So who's high risk? Are Jerry's, age greater than 60. Comorbid illnesses. And what do we mean by that? Well, if they've got a history of ACS, right? If they got diabetes, if they have eczema, is that comorbid illness? Like, shut up, right? I'm not saying that. Think about things that will hurt them long term. Already mentioned the vital signs there. And then also bright red blood cells, or bright red blood in the NG aspirate or upon rectal examination. Those folks are high risk. They need 1-to-1 care. Okay. Follow-on care, EGD, right, that upper GI series, or putting a camera down their throat. Warranted in all patients with active upper GI bleed. So within 24 hours of presentation, we're getting a camera and we're going to go looking. We're going to go hunting. If they're unstable, we're doing it sooner. It's diagnostic and it's therapeutic. As I mentioned yesterday, we can stick all kinds of different tools through that flexible thing, right? And cauterize, band, do all kinds of sort of things. It's really nice. And also it's prognostic. You'll be able to look at blood vessels, and you should become more familiar with these things, talking about tissue as friable. And hopefully you've heard that word before. That means that if you touch it, it'll bleed. Now we talk about the nasal septum constantly. Is it a friable nasal septum? You can have a friable cervix. You have a friable gastric mucosal. Right? You can talk about those things. See, like, hey, if we bump into that, it's going to start bleeding. So that's prognostic. Pharmacotherapy. These patients with upper GI bleeds, they're getting a proton pump inhibitor. 100% are getting it. Generally, it is IV. You can do it PO, but generally it's done IV. This is going to lower the risk of rebleeds for ulcers. It's going to reduce the risk of erosive esophagitis, gastritis, and/or Mallory-Weiss tear. I said yesterday, we talked about octreotide, and here we are. That can reduce the portal blood pressure. Just think about anatomically, all of the blood in the body gets siphoned through the liver en masse, right, relative to the other organs. So if we can reduce the amount of pressure there in that portal system, we could potentially reduce how large and congested the veins are in the esophagus. That's the purpose of the octreotide. Questions? Again, that was just an overview. We're going to talk specifically about this stuff going forward. Lower GI. So this is bleeding distal to ligament nephritis. Majority of lower GI bleeding is coming from the colon. Typically lower risk of serious blood loss than acute upper GI. So again, interesting. Who's going to present to you as unstable? Is it more likely to be an upper GI bleed or a lower GI bleed? telling you right now, the person that's more likely to be unstable is that upper GI bleeding patient. Okay. Why do they bleed from down below? Anorectal disease, could be hemorrhoids, fissures, ulcers, all innocuous, right? I mean, it sucks for them, but we're not thinking it's going to kill you. Diverticulosis, painless, bright red blood, large volume. I'm not giving you milliliters here. This is in quotations. What is large? Hear me out. They went potty, they got up, the toilet bowl's covered in red blood. That's large. They wiped their butt, and there's a bit of blood in the toilet paper, not large, not diverticulosis, okay? Toilet bowl full of blood, red, jaws is in there, it's a murder scene, that's okay, all the same thing. Inflammatory bowel disease, right? Ulcerative colitis, Crohn's disease, infectious colitis, cancer, angiochetasis, typically more common in our gerries, and ischemic colitis. Those can all cause acute lower GI bleeds, and we'll talk about those things. How do they present? Hematochezia. This can be painful or painless. So what helps us determine the etiology? Several things. First off, the age. If they're less than 50 and they're bleeding from down there, we're thinking anorectal disease. Maybe this is inflammatory bowel disease. Maybe this is infectious colitis. Greater than 50, and they're bleeding down below, one of the first things on your differential must be diverticulosis. It must be. Another must be is malignancy. Because when are they supposed to get their colonoscopies, right? Before they're 50, okay? We'll hit on that in a few lectures as well. The angiochetasis I mentioned, and then ischemic colitis. These are not absolute, they're just most likely given the patient's age. And that stuff matters. In our vignettes, these things matter. Demographics matter. Epidemiological data matters. If I tell you that a certain age group gets a certain thing, trust me, that age group will present on the test that way. Now I tell you that ethnicity presents a certain way, trust me, it'll be there. Same thing, if there's any gender bias, I will let you know. Other things that can give us clues. The color of the blood. Is it bright red? We're thinking left colonic source. Is it maroon? Not the T-Swift maroon, but like not so great. Small intestine, right colonic source. And then black, upper GI. Is it painful? If they've got pain, we're thinking this is non-emergent. Hemorrhoids, sucks. Anal fissures, really sucks. Not going to kill you though. If they've got abdominal pain associated with it, you need to be thinking inflammatory bowel disease. That's our Crohn's or ulcerative colitis. Other colitis. If it's painless, you think about internal hemorrhoids, and we'll have a whole discussion about where that line is, that thick line, what makes a hemorrhoid painful versus not painful, or diverticular bleeding. And then volume loss. So large volume, toilet bowl, full of blood, that's diverticular bleeding. Small volume, maybe just a little bit of bloody diarrhea. Is it blood smeared stool? Okay. And then the hemorrhoids, the small drips into the toilet, blood when wiping, bloody streaks on the stool. I mentioned, right, the rare lower GI may lead to significant blood loss. If they're unstable, you intervene. That's the bottom line. Eval looks very similar to our upper GI bleed. However, because most of these patients are stable, we're doing a bit more medicine here. Now we're going to go ahead and order that iron panel. We're going to look at the iron studies, where we weren't saying that before with the upper GI bleeds. Because now I'm worried about, is this an occult bleed? What's happening here? Are we depleting iron stores because this person is bleeding out? Microcytic anemia suggests long-term bleeding with loss of iron stores. And it's an ominous sign. Okay, we should be thinking cancer in that case. So Diagnostic testing, first, exclude upper GI source. And you can do that in a variety of ways, as we already mentioned. All right, well, we've got a lot of tools for us to use up the butt, which is great. So a colonoscopy, anoscopy, sigmoidoscopy, actinium scan, angiography, and capsule endoscopy. And I'll show you some images of what these things look like. So the anoscope, this is an outpatient procedure, no sedation is required. You just go in, you're able to look at anus, the rectum, and see what's there. Very helpful when you are assessing hemorrhoids. That's what that's used for. Flexible sigmoidoscope. So before we had the full-on C-scope or colonoscope, we were afraid to go past the splenic flexion. We were. So we just went, we just did that. Just looked at the sigmoid and we were done. Okay? That's why the sigmoid scope existed that way. As we get into block 2, we talk about ulcerative colitis versus Crohn's. There'll also be some pathologies that are specific, that are just sigmoid versus whole colon. And then colonoscope. That thing's looking at the whole kit and caboodle, right? We're twisting and turning and hitting that splenic flexure, going across the transverse colon, twisting and pushing again, going down the hepatic flexure, right? It's a whole ordeal. You'll break a sweat. Right? The patient won't, because they'll be anesthetized, which is great. Get a little propofol down. Actinium scan, so we're now talking nuclear medicine, if this is available for you. And what are we looking for? We're looking for blood loss. And that's the main reason that we're doing this, occult blood loss. We can only, on the upper GI side, go down pretty much to the duodenum. It's about as far as we can get. And then on the lower GI side, I can get all the way to the sphincter on the right side there. Right? That's really it. I can't go into the ileum and look. Same thing with an arteriogram. We're looking for those occult bleeds. And there's that capsule endoscopy. And we're utilizing this when we've gone in both ends and we didn't find the source of the bleed. And maybe we don't have nuclear medicine. Maybe the bleed's in the duodenum or the ileum. And this capsule endoscopy will be able to help us find that. It's just taking pictures the whole time that it's going through. Treatments for acute lower GI bleeds, large volume bleeding. We do a therapeutic colonoscopy, so we just go in and we're injecting with epinephrine, we're doing cautery, we're doing clips and bands. We can do intra-arterial embolization as well, so you go through the femoral artery, and then full-on surgery. But I just mentioned to you it's not surgery. It's not a surgeon that's performing those things. It's a gastroenterologist, which is an internal medicine physician who is specially trained in gastroenterology, not a surgeon. But if we need to do surgery, we can. Laparoscopic or full-on, right? Open the whole abdomen, find it, cut it, clip it. Questions on the lower GI bleeds? Having a bad day. It's okay though. It's a good Halloween idea. All right, obscure bleeding, obscure GI bleeding. It persists after initial upper and lower endoscopic evaluation. Commonly, this is from the small intestine somewhere. We've got obscure overt versus obscure occult. We're getting into some nuance. So occult, bleeding that's not apparent to the patient, no overt signs of bleeding or change in stool color. They can lose up to 100 milliliters a day without any appreciable signs. And what kind of signs are we asking about? Fatigue, lightheadedness, dizziness, numbness, tingling, none of that. They're just bleeding out their gut every single day. We identify it in a number of ways. Fecal occult blood, fecal immunochemical tests, and then presence of an unexplained anemia on CBC and iron panels. On the occult GI bleed, we must investigate for cancer before neoplasm. So we obtain the CBC to check for anemia, get the iron panel, we search for the source. Now pay attention to this. So we've got occult bleeding without anemia. Your standard of care is just doing the colonoscopy. that's fine. If you've got occult bleeding with anemia, we're going both ways. We've got to see where this bleed is coming from. Again, ruling out the source of the bleed. And if both of those scopes are equivocal, that's when you're thinking, I need to do an additional type of scan, actinium scan, radionucleotide scan, an angiogram, the endoscopic capsule that I mentioned earlier. So there it is as a picture. It's nice. It has words, pictures and words. These are learning tools. What questions do you have generally about GI bleeding? Okay, well now we're going to get into pathology. Now it's going to be fun. No more of these generalities. Okay. First up, question. Check on learning. Who said that? Doesn't. Who agrees? He doesn't.
Yeah, he got fired.
He got fired. Who said that? Yeah. That's crazy. I love Formula One. It's so great. Yeah. He got fired. He's a little bit of a pervert. Not that there's anything wrong with that, as long as you're not hurting anybody. He did some weirdness. Okay, that's Ginger Spice, by the way, his wife. She doesn't mind about the weirdness. They're still together. It's great. Therapy and whatnot. Okay, so the esophagus. Anatomical review. What is it? It's the tube that connects the food hole to the food bag. Right? That's what it is. That's what it does. In pictures, that's what it looks like. Great. Nice review. Words. Heartburn, pyrosis. I remember heartburn does not equal dyspepsia. I saw that yesterday. I'm going to get one of you on that. I promise you. What is pyrosis or heartburn? Substernal burning sensation, substernal, not epigastric. It's due to reflux of material into the esophagus. And then we have two words that you must become familiar with. These are more alarm words when you're hearing these sorts of things. If you're describing sorts of things, if I'm describing a symptom in this way, should be alarming. Dysphagia, difficulty, odynophagia, painful. Any of those things are happening, we're thinking badness when it comes to the upper GI. With dysphagia, oropharyngeal, they've got this immediate sense of like a bolus catching in their neck, and they might do a little bit of rock and roll headbanging, trying to get it down. Esophageal, typically it's due to some type of mechanical obstruction or motility disorder. Mechanical, you'll ask the patient, so when you're swallowing, are you able to swallow solids and liquids without issue? And they're like, well, solids it's pretty bad, liquids no issue. We're thinking mechanical. Motility, it'll be both, solids and liquids. What do we do to evaluate these folks? Study-wise, EGD, study of choice, direct visualization, and I can stick a little probe in there and take a piece of tissue and send it to pathologist. It'll be really nice. Barium swallow, used when you were thinking about motility disorders. I'll show you some pictures of that. Esophageal manometry, just testing the function of the lower esophageal sphincter. And there's also some esophageal pH testing. We don't do that as often anymore, but you could do that if you were thinking about GERD. It's a super strange test. They take this string, you swallow it, and you tape it to the side of your mouth for a day or two, and then you give it back to them. Yeah, what a weird. Just think when you're doing this stuff to people. Just think about what you're doing. Okay. All right, so let's talk GERD. Reflux. Acid reflux, acid indigestion. It's a reflux of stomach contents into the esophagus, which can lead to structural changes. We'll talk about Barrett's esophagus in a second as well. Majority of these patients have mild disease, but if we don't treat it, it can get bad enough to where they get cancer, adenocarcinoma. Okay. What causes it? It's dysfunction of the lower esophageal sphincter, possibly a hiatal hernia. We'll talk about those. Some abnormal esophageal clearance, delayed gastric emptying. Remember what endocrinologic disorder causes that? Diabetes. Okay. And then gastric acid hypersecretion, like a Zollinger-Ellison syndrome, right? Genetic disorder. Again, another endocrinologic tumor that's related to GI. Pathophys, what happens? We've got this extra acidic material that's coming in contact with the esophagus and just burns it away. Prolonged exposure to that acidic material can cause transformation of those cells. And we worry about this, specifically this place called the Z-line, or the squamocolumnar junction within the esophagus and the stomach. On one side, you've got squamous cells. On the other side, you've got columnar cells. We'll talk again briefly with one slide on the next PowerPoint. Remember how the gastric mucosa looks? It's all columnar cells. Your goblet things and the master chiefs, all the stupid stuff, right? But now with that line, it's between those cool things and then just normal squamous cell mucosa. And enough gastric regurgitation up into the esophagus can cause those cells to change and become dysplastic. So heartburn, reflux, regurgitation typically happens 30 to 60 minutes after a meal, or when they're lying down, or they're in their lazy boy. Patients will also say, hey, I tried this, I tried the Tums, and it helped. These patients might also complain of what's called water brash. This is when they get that weird acidic or metallic taste in their mouth, where they just start salivating for no reason. More importantly though, they may complain just of a cough. And here's our overlap to pulmonology. If someone's coming to you and chief complaint is cough, you 1000% are allowed to think GERD, the third most common cause of cough. And why? Why are we coughing? Well, we're getting enough regurgitation into the epiglottis, into the trachea. It's going down, right? That's the reasoning for the cough. Other symptoms, dysphagia. They have dysphagia, we're thinking this is bad. This is advanced disease. The globus sensation, that's that feeling in your throat, something stuck in your throat. They may have laryngitis, sore throat. They could have chest pain. Maybe difficulty with sleeping. Why? Because they're recumbent there. Physical exam, not helpful, generally. Still going to do it though. You're still going to palpate the belly and listen and do those things. You're still going to do an HENT, look in the mouth, look in the throat, check their dentition. Because sometimes you might see erosions, right? Keep back on those molars. That's why we taught you dental. Right? No other reason. Everything else is irrelevant. Differential diagnosis, esophageal motility disorders, peptic ulcer disease, which we'll hit on, angina pectoris using ACS, right? Other functional disorders, and eosinophilic esophagitis. So work up there. This is a clinical diagnosis. So ultimately, we don't have to do anything initially. We don't, unless there's alarm signs. And these alarm signs, I've showed them to you several times already. They're pretty consistent. Maybe it's 50 versus 70 or 50 versus 60. Just think, if they're old enough to know who the lead singer of Van Halen is, right? It's an alarm symptom, right? That's an alarm symptom for you. Dysphagia, I mentioned. Odynophagia. Unintentional weight loss. All those general parts, those B symptoms, you need to be worried. Lymphadenopathy. Now, there are certain cancers that will make lymph nodes super big for no other reason. Cancer from the GI tract, lymph node wise, lives right here supraclavicular. I guess what you guys weren't doing last semester. We weren't checking Cooper, you aren't doing that. But that they live there. If you feel a weirdness here, I'm thinking cancer. Okay. And then unexplained iron deficiency anemia, family history of upper GI cancer, of course. Patients that continue to experience symptoms despite any empiric anti-acid treatment, they require an EGD. I just told you, right? You don't actually have to do anything initially. As long as there's no alarm symptoms, and it looks like, sounds like, smells like, this is GERD, you can just trial them on meds. But what this is saying is that if they're not getting better, then you go take a look. Then you go take some tissue. The EGD is the test of choice for GERD. Because not only can we get macroscopic visualization, but we're also going to be able to get slide from the pathologist. We're going to also be able to dye that tissue and look for something called H. pylori, which I mentioned yesterday. We do a lot of stuff. We can look at the eosinophils, look at the infiltrates. We can do a bunch of things. We can rule out a whole bunch by doing the EGD, and that's why it's a study of choice. Esophageal pH, lower esophageal sphincter, manometry, that can be ordered by a specialist. This is a nice to know. There are several different ways to classify macroscopically how bad that lower esophageal sphincter looks. How do we treat it? So I've got to go in two different ways here. So in current, it says all of this. Now, there are several associations like the American Academy of Gastroenterologists where they say all of this is BS. I'm telling you, this is what current says. So you talk to them about eating smaller meals, you talk to them about acidic foods, spicy foods. So I want, hey, those things, that's in your diet, stop doing that. It's also a tough sell. Right? Hey, the diet that you grew up on for so long, I want you to stop that. Good luck. All right, just good luck. But things we can talk about is continuing tobacco use, nicotine. And the reason behind this is scientific. All of these foods, all of these things, capsaicin, nicotine, alcohol, they lower the tightness of that lower esophageal sphincter. So it allows it to release a little bit, releases that smooth muscle. So the idea is if you reduce the amount of that, you should have tighter lower esophageal sphincter, no more GERD. That's the idea. It's just difficult to get patients to stop doing this stuff, is all I'm saying. And that's what the physicians, the gastroenterologists, recognize. Things that do work, though, avoid the lying down. So you have a big meal, and then you lie down to watch the game. Don't. Maybe sit up before you recline. Talk to them about that. What do you typically do after you're done eating? Are they eating so close to bedtime? Right? And some folks do. Some people are in shift work. That's what the heck they do. You have to have those conversations. That's why social history now is relevant to you. It's not just like, what's your MOS? What do you do? What are your hours like? When are you eating? You can elevate the head of the bed, certainly can help, and then weight loss across the board. The more adiposity that exists within the trunk, the more intra-abdominal pressure will exist. This is basic physics. So if we reduce the amount of tissue around the abdominal cavity, we should reduce the pressure there, so they have less GERD symptoms. Treatment-wise, where can we start? H2 blockers. Now we're talking cimetidine, famotidine. You can do the antacids, so that's like Tums, Rolaids. And with those H2 receptors, Zantac was in the news maybe 7 or 8 years ago. It caused cancer. That's what they found. So they stopped. But then they rebranded it. They rebranded the names. Now it's famotidine. So now there's 2 famotidine generics. Just saying, it's fun to know these things. To look at them. But they're there. If someone's going to use an OTC antacid and they have CKD, we need to have a conversation. If they're going to take any medication that is CKD, we should have a conversation. thing of hypercalcemia in these patients, and that can be bad. For the H2s, they generally work all right. They're okay if they have very mild symptoms. If they have very mild symptoms, guess what they probably didn't do? Come see you. Okay, so they probably already tried this, right? But onset action, 30 minutes, duration's 8 hours, not too bad. But here's the moneymaker. This is the good one, right? The PPI. And I mentioned yesterday, there is I had a question afterwards about the Cochrane study that looked at the prospective trial of folks that are on PPIs and early onset dementia. Still out there. There's now debate. There's some debate. There's been several letters to the editor from several physicians saying those studies are confounded because they're prospective, etc. Take what you will, right? Just know that for GERD, the best medication, the one that's first line, is this one. Okay? Any of those folks at the lowest dose possible. Okay? It's once daily dosing, generally, outside of when we talk about treatment for H. pylori, right? So that was multiple times a day. But here for just normal GERD, once daily, 30 minutes before breakfast. And what I typically tell patients, in order to ensure that happens, hey, when you wake up, you're about to brush your teeth, take your med. Right? When they'll brush their teeth, they'll get ready, and then they can go and eat breakfast, do whatever they're going to do. Maybe it's 20 minutes. It just ensures that's there, right? It needs to be taken on the stomach. It's a very volatile molecule, right? So it needs its own little environment to go and do its thing. So mild, as I mentioned, right, so this is less than 2 episodes of their GERD symptoms a week. It's fine. As needed, antacids, as needed, H2 blocker, right, completely fine. If it's troublesome, i.e. they came to see you, our go-to, we're looking at a PPI. And we're trialing that for 8 weeks. So when am I seeing you back? Not next week, not in 2 weeks. I'll see you back in 6 to 8 weeks. That's great for you. You're going to see them again, okay? And we know it's going to work. They're really good, highly efficacious. We start low, and we just step up the symptom control. So if by week 3, they're like, hey, I'm still symptomatic, and they call, we'll bump it up. Instead of the 10 mg, let's do 20 mg. Instead of 20 mg, let's do 40 mg. So just once a day, you're good. If you try to titrate, if you try to play around, you're at the 8-week mark. They're still not improving. We need to stick a camera down the throat. Okay, what's going on? We're missing something. We're really missing something. Some patients, if we know that they have erosive esophagitis, they're near that Barrett's, and we'll talk to you about Barrett's in a bit. They may be on PPIs for a long time, possibly for the rest of their lives, because the risk of cancer outweighs those risks of those other things I mentioned before, the dementia, early onset dementia, chronic kidney disease, etc. And in any patient with alarm syndrome, we're sending for an EGD. You're supposed to discontinue the PPI once their symptoms are resolved. Just like you would discontinue Motrin after their knee or back stopped hurting, right? Same principle applies here. You're supposed to discontinue it. You're supposed to prune it off. And if you're not pruning it off, and you haven't done an EGD, you are wrong. Okay. And as it says there, most patients do relapse. There's some surgical options as well. I'm only going to talk about one surgical option. There are they use magnets now. They'll put magnets inside the abdomen around the esophagus. Think about it, it's a proton, right? That's why we get the acids, it's H+. So you can do things that's crazy. That's science working. It's kind of cool. But the Nissen fundoplication, that's kind of a standard one that we use. And they go in laparoscopically, they just take a bit of the cardia of the stomach and just wrap it around the esophagus to tighten that lower esophageal sphincter. Works very well. That's what it looks like. I have no idea what I'm looking at. But you're probably holding the camera. You're like, cool. Right, cool. So complications of GERD. As I mentioned, the Barrett's esophagus, or esophagitis. This has a high risk of turning into cancer, adenocarcinoma specifically. And the thing is, with Barrett's, these patients may eventually become asymptomatic. They'll have bad GERD, and then all of a sudden, it doesn't bother me anymore. And try to consider why that's the case. Because there's been dysplasia. Right? So once where there was, or were, squamous cells, now it's columnar cells that are all kinds of weird. Right? And so that's why they no longer have the pain. The sensory overload is no longer there. That's bad. That's ominous. Here's what it looks like. Patchy, gross. It looks like they had a road rash in their esophagus. And considering that it's a pH of 4 on exposed tissue, that's kind of what it is, right? Final complication we'll talk about before the break are peptic strictures. So this is just narrowing of the esophageal lumen at that gastroesophageal junction. You have progressive solid food dysplasia and dysfunction. And again, so why? Why is this happening? Well, there's so many acidic contents going up and killing the squamous cells that it just starts to reproduce over and over and over again and get smaller and smaller and smaller. That's the so what there. You treat it with dilation. This happens multiple times. They're going back to get redilated maybe once a year. So they're not having that dysphagia or that globus sensation. Questions on GERD? No. All right, let's take 10. Okay. So let's start now with esophagitis. So 3 main subcategories of esophagitis. You got infectious, you got pill-induced, and eosinophilic. I'll point out to you the things that are most important. But when we're thinking infectious esophagitis, you think about candidiasis, CMV, herpes. So what is it? Irritation, inflammation, swelling of the esophagus due to infection with a fungus, yeast, viruses. Who is this occurring in? Immunocompromised patients. So that's going to be a key part of the vignette that you need to pay attention to, because I've not spoken to you about this before. Right? So they could come to you with dyspepsia, but if I tell you they're HIV positive, you better be thanking me. Okay? So folks with AIDS, post-transplant, leukemia, lymphoma, they're on chronic immunosuppressive drugs, i.e. steroids, long-term steroids. There are certain medications we will give that are called biologics to folks that have inflammatory bowel disease that can make you immunocompromised as well. Rheumatoid arthritis, any of those rheumatologic disorders can impact the immune system. So they can complain of dysphagia or diaphagia, possibly chest pain. How are we diagnosing this? We've got to do a scope. They come to you, they're immunocompromised, they've got dysphagia or diaphagia. I don't care if they have normal GERD symptoms. Your first instinct should be, let's take a picture. Let's go look at it, right? And let's take a biopsy. The treatment will be directed at a specific etiology. And here's what we see. It looks exactly as it looks anywhere else on mucosal surfaces of the body. So candidiasis, remember back to micro, and we will talk about it additionally in infectious disease, curd-like, right, could scrape it off. I'm talking about in the esophagus now. What does herpes look like, right? Multiple, numerous erythematous vesicles. CMV, erosive. That's how I'll describe it. That's what it will look like. Next one with esophagitis is pill-induced esophagitis. This one's funny. So we give you a pill, it's the size of your fist, and then you gotta swallow it. Well, you do that enough times, and sometimes it can cause erosion of the esophagus. Even more so, some of the active ingredients in these medications can just cause inflammation. And so medications I want you to pay attention to, NSAIDs. And generally that's due because they're super big, and also because of how they act on COX, right? That enzyme, COX-1 and COX-2. Other things like potassium chloride, those bisphosphonates, so alginate, bisglycinate, those are things that you may prescribe here in the near term. Iron can do this, vitamin C can certainly do this as well, ascorbic acid. And then look at the antibiotics. All the tetracyclines are there, which you will prescribe. And think about prophylaxis for malaria. So 9 to 12 months of taking the medication that can cause esophagitis. And then they get back and they have GERD-like symptoms. Maybe this was the causative agent. Maybe it'll just resolve. Should they get a PPI still? You betcha. And you can see Scepters on there as well, and clindamycin. And why are you prescribing clindamycin in the first place? What's wrong with you? Right? It's got a black box warning on C. diff. There's hardly anything that we need Clinda for first line. Third subcategory, eosinophilic esophagitis. So this is an immune-mediated inflammatory response to the esophagus to an allergen, to either food, it's environmental. This is an eosinophilic infiltration into the mucosa. And the inflammation then leads to progressive dysphagia, difficulty swallowing. You get a narrowing of the esophageal lumen. What is this patient going to look like? They're going to look atopic, in the vignette at least. They're going to have a history of asthma. They're going to have a history of allergies, eczema or atopic derm. That's going to set them apart. They're going to have the dysphagia to solid foods. That's the common presenting complaint. They're going to have heartburn. Here we need to take a picture, and more importantly, we need to take tissue. We've got to get the biopsy to send to the pathologist. And we'll see eosinophilic infiltrates in the specimens. How do we treat it? Pretty easy, UPI. They need to go see an allergist and or GI. They can also do what we call topical corticosteroids, and we'll hit this more in block 2. When we talk about the GI system and we talk topical, it just means that it's coating the mucosa. And you can have topical treatments that you take orally or per rectum. Right? They're both topical. And how do we do the topical corticosteroids here? You just do swallowed fluticasone from an inhaler. Some of the reasons for dysphagia, the esophageal webs and rings. The webs are thin membranes of squamous epithelium, mid to upper esophagus. Most are asymptomatic, but it can cause intermittent dysphagia or GERD-like symptoms. You also see these things called rings or Schatzky rings, circumferential mucosal stricture of the distal esophagus. Strong association here with hiatal hernias. How do we diagnose it? Barium swallow, and hopefully you can see. My pointer works. All right, there. You can see that there's normal contrast, and then it comes in on itself, and then goes back out. That's what we're seeing. That's the pathology right there. It's a slam dunk. Other reasons for dysphagia. Zinker's diverticulum. This is a pharyngeal pouch, a pharyngeoesophageal diverticulum, an outpouching of the esophagus. They've got progressive dysphagia, a sensation of food sticking in the back of their throat. Their breath smell bad, smell like trash. Why? Because the food is digesting up here versus in the stomach and in the gut. You can also get regurgitation of undigested food, pills. We diagnose this with a barium swallow. Here anatomically is what it looks like. You can see that outpouching there along those smooth muscles. And you can see with that barium swallow is also now it's like a little egg that comes out. Achalasia, idiopathic esophageal motility disorder. This is a loss of normal peristalsis in the distal two-thirds of the esophagus, impaired relaxation of the lower esophageal sphincter. They'll have progressive dysphagia to solids and liquids, regurgitation of undigested foods, substernal discomfort. These are the folks that you certainly will see trying to perform maneuvers to try and get it to go all the way down, move around, with their head back. And you can see weight loss. Why? Because it just sucks to eat. That's the main reason, right? There's no B symptom. Physical exam, unremarkable. Did I talk about bad breath at all? I didn't really say that. So again, I'm showing you different ways that these folks will present. Diagnostic study, you'll do a barium swallow, you'll see this beak, or this bird's beak deformity. I'll show you a picture of that. It's a tapering of the disproportion of the esophagus. EGD and esophageal manometry is utilized to confirm. And there's that bird's beak. They like to name things radiographically after animals. I think it's super strange. And fruits, I don't know why. But sure, it looks like a bird to me. Whatever. Differentials, Chagas disease, Trypanosome cruzi, right? That's a good one. It's a parasitic disease, endemic to Mexico, South and Central America. I diagnosed this by accident. It's funny. You're supposed to screen folks when you deploy because you're doing the one things and stuff. This is one of the ones you screen for. Guy actually he had chest pain in the back. It was the whole thing. Crazy. Okay. Treatment. They need to go see GI. Possibly need to go see general surgery. They can do botulinum toxin injections into the lower esophageal sphincter, pneumatic dilation, or ultimately surgery. Questions about the dysphagia stuff? Yeah.
The motility issue, should we think of it like neuro kind of deficit, or what's? I'm thinking like kind of like ileus kind of sense.
Idiopathic.
Idiopathic.
We
Okay.
don't know.
Okay.
Any questions? All right, let's get into the bloody stuff. This is fun. Upper GI bleeding, esophageal varices. These are dilated submucosal veins due to portal hypertension. And why do they have portal hypertension? Well, in most cases, greater than 50%, it's due to cirrhosis. Who typically gets cirrhosis?
Alcoholics.
Folks with some type of hepatitis. Alcoholics included, right? That's what it is. Steatohepatitis. They get it. Or it could be Hep B, Hep C as well. Causes severe upper GI bleeding, high mortality rate. Very high mortality rate. Emergent treatment, you stabilize them. You volume resuscitate. Try and manage the portal hypertension. Where I try to identify where the bleed's from and provide hemostasis. And we do that with the EGD. Follow on, we're going to do reduction of the portal hypertension, possibly some type of beta blockade with propanolol, variceal band ligation. And then you can see, right? I showed you in this kind of picture of the esophagus earlier, right? There were no mountain ranges in there, okay? That's abnormal. And then when one of those things goes to bleeding, it's bleeding hard. Just think about anatomically. Straight from portal vein, esophagus, right? So yes, it doesn't flow down, certainly, but if it's congested up here, that means there's a backflow. All that blood that's going through the liver is now coming out into the esophagus. That's why it's so bad, that's why it's so fatal. On top of the fact, this patient already is cirrhotic, more likely than not. They're already sick. Another type of bleed we have is the Mallory-Weiss syndrome, Mallory-Weiss tear. This is a mucosal tear of the GEJ, that gastroesophageal junction. Sudden increase in abdominal pressure due to retching or vomiting. A very strong association with alcoholism. Why? They're throwing up a whole bunch. But you can get a Mallory-Weiss tear with a bad norovirus, with a bad flu, with enough retching. And that's why every time we talk to a patient about what the heck is coming out from above or down below, we specifically ask the question, is there blood? Can cause an acute upper GI bleed, and that patient will present with hematemesis. We ask about those predisposing factors, the alcohol, talk about recent sickness. Once they're stabilized, they're getting endoscopy. We can put an epi, we can do cautery, we can do an endoclip. You can see there's just that stretching of the esophagus that then incites a bleed. Typically these aren't that bad though. The Mallory-Weiss tears are generally not that bad. So what can be even worse is a thing called Borhe syndrome. So now we've got a complete rupture of the esophagus. And now we've got stomach contents going into the mediastinum, causing a new mediastinum. It can cause shock, just overall general badness. Very high mortality rate with this. So we're thinking on a spectrum, right? It could be someone doing a whole lot of vomiting, and they get a Mallory-Weiss tear, and they continue vomiting, and then it finally just ruptures entirely. That could be Borhe. Or another way, motor vehicle accident, some type of blunt trauma. Maybe they were playing Karate Kid and got kicked in the chest, right? Totally could happen. So there it is in pictures. Questions on those upper GI bleeds. And don't forget about starting PPIs, right? I mentioned that in the intro. Don't forget about octreotide, right? All those things down. We talk about lowering some of the pressures in the hepatic portal system. Talking about octreotide, talking about propanolol, all those things. We're utilizing a PPI to reduce the risk of rebleeding. All right, esophageal carcinoma. Relatively rare here in this country. Relatively rare. 3-to-1 male to female ratio though. Can be squamous cell or adenocarcinoma. And what might cause the adenocarcinoma? Barrett's, right? Yeah, Barrett's, good. Most present late with advanced disease. Another thing not on the slide, but something to be aware of, is that this is location dependent. I mentioned here it's rare. In Asia, not so much. More common over there relative to lower GI neoplasms. So over here in Western side, we do colonoscopies as part of preventive medicine. In Asia, they do upper GI endoscopy and not colonoscopy. I'm giving you American medicine here for this. Risk factors, tobacco use, obesity, and yes, obesity is a risk factor for cancer inherently due to cystic inflammation, and then GERD/Barrett's. These folks have progressive solid food dysphagia, vaginoaphasia, significant unexplained weight loss. Well, sounds a lot like achalasia. How would I know the difference? More history, right? More history, but I probably have to do a scope. Probably do some type of testing, right? Determine the difference between the two. Another thing that's different here is they've got more systemic symptoms. Body aches, pains, and that's consistent with metastasis because I already informed you this presents late. So you're getting all of the bad symptoms at once if I'm giving you a vignette. Okay. Another way for you to differentiate. Diagnosis, no specific lab findings, do whatever, shotgun, you're screaming, it's weird, you don't know what's going on here. But the EGD, that's gonna tell you a lot, because you're gonna see that. Okay. Also not good, that's like a bunch of bushes in your esophagus. You don't need bushes in there, right? You don't need like a little tiny brain inside your esophagus. Not good. Like, trust your gut, but don't have a brain growing in it. Treatment depends on staging. It involves surgery, chemotherapy, radiotherapy, some combination thereof. You're gonna get more of that stuff in HEMONC when you guys are seniors. Prognosis is poor. Those are bad numbers, y'all. Less than 20% 5-year survival rate, that's rough. But again, all these numbers associated with here on the western side, they're catching this cancer earlier over in Asia. It still exists, still neoplasm you need to be aware of. Something to consider when someone has dysphagia or gynophagia, it's progressing, it's getting worse, they're losing weight. If you're thinking adenocarcinoma, not wrong. Squamous cell carcinoma, you're not wrong. It's probably not that, but it should be considered. Questions? Yes?
This has to be specific, what is Asia side of the house doing are catching this early?
Upper GI, yes, the upper GI series. So the prevalence and incidence of this cancer is at the same rate that ours is for colon cancer. So the way that they think about USPSTF, that preventative task force, when they look at the numbers for their population, they're like, upper GI makes more sense than lower GI. And on our standpoint, we're like, lower GI makes more sense than upper GI. And they don't know why. They hypothesize, is it diet related? Maybe. Is it genetic loading? More possibly.
I mean, if you're already like bringing somebody on their vacation, but it's gonna like walk and flow.
Yeah, let's do it all. Like, have a party. What else? Yeah.
Just a factor that comes to my mind is it's the 5-year survival. Would that be because we're just discovering it so late
So
in life?
late.
So it's like you're going to find it on 9-year-old. Well, they're going to only live 5 years anyway. So.
Or they may be 45.
Okay, I'm wondering what the demographic is that's typically found on for the
You're
esophageal
thinking mid-adult.
mid-adult. Okay.
That's what sucks, again. And what, again, it's like you're stating, the reason that the mortality rate is so high is that it's pretty much asymptomatic until it's super bad. Those are the kind of cancers that are the worst. Right? And that's why we do screening tests for them. But this doesn't happen enough in Western society to where USPSTF has decided we're going to go on both ends. Now, however, if you've got Barrett's esophagitis, you're going to regularly get an EGD. Why? Because your risk of cancer is now higher. We know it. We know it's higher. So now it's going to be incorporated into your normal prevention, if that makes sense. What else? Okay, that's all I got for today.